Perfect. So thank you so much for having me. It's always a pleasure, and I always like to talk to people out of the country. Such an important topic, and the international interest is great, and I love that. I have put my social media on top there because a lot of people reach out and have questions, so I just wanted to point that out at the beginning. So here today, I'm going to speak to you about plant-based diets and whether they're actually any good. My disclosures are I receive honoraria for speaking and royalties from books, and I do sit on some nutraceutical advisory boards. So why am I here? So as Rohini kindly introduced me, I'm a preventive cardiologist. So people come to me when they have advanced heart disease, they need bypass surgery, they've been told they need stents, or they have stents and they keep needing stents. Or I see patients who have really advanced heart disease or just are worried about their risk. I see a lot of women, I see a lot of South Asians and Asians in particular because of my own history and my own interest in Asian and heart disease. So these are the areas I focus on, and people come to me sort of with all these interests, but they also come to me because they have inflammatory disease. So why is that? Well, I'm not only am I a preventive cardiologist, but I'm also a researcher. So I do a lot of research at the University of Florida where I focus on the impact of the things that we do in terms of nutrition and lifestyle and how those impact your risk of illness. I'm currently finishing up a study on olive oil, which is super exciting for me. I'm also a mom. I have 3 children. They are the greatest joy of my life. After having 3 miscarriages, one of which was fairly late on, I have cannot express enough how much I value and appreciate having these kiddos in my life. I'm also an athlete. I pride myself on always being a runner. It is my stress relief, but I'm also a triathlete. I like to run. I like to do marathons, and I take those roles seriously. But what maybe some of you don't know, or some of you do know now, is that I'm also a patient. So about 10 years ago, I was diagnosed with a debilitating form of rheumatoid arthritis. I went from being an active runner to being unable to climb up the steps. I had a 4-year-old, 2-year-old, and a newborn at the time, and slowly, or rather quickly, saw my life change from active health to full-on disability. I went through a process of being told that I had such an advanced form of the disease that I needed to get started on multiple medications for my health. I was told that I had such an advanced case that if I didn't get on medications within a week, there was some concern about how I would do overall, and prognostically, my numbers were so advanced and so abnormal. So I did what I had to do. I did get on the medications. Within a week, I had to stop nursing my 4-month-old child. And there is no, people who've ever nursed a baby know that that's a pain, that that kind of control and loss of control was very difficult for me. So how did I feel? Well, I was scared all the time, as any patient is. I felt emotional and fragile. I was unable to understand how this happened. I didn't feel in control, and I was angry. I was angry at my kid, angry at the choices I'd made, and wondered why I had tempted fate, quote unquote. And that's something that I'd often considered. But my story isn't a new one. The doctor becoming the patient, or feeling sick, or all of us getting sick, because as we get older, there's more and more disease. I just read the news before I came on here, and Ray Liotta died in his sleep. And we have so many cases of people as we getting older. We're knowing more and more people that have passed away. The youngest person that we stented with an acute heart attack, now my youngest patient is 29 years old. So what is it that all of these patients have in common, or why are we all getting sick? Well, there's a fundamental problem, and that fundamental problem is inflammation. I always tell people that inflammation's like your body's mad at you, your body's on fire, which is the name of our book, actually, because we believe that body on fire is what's the problem. So much inflammation or body irritation. So arguably the pillar that's in between all of these all of these illnesses is inflammation. And if you, whether you get heart disease or rheumatoid arthritis or irritable bowel or inflammatory bowel disease, is maybe based on your genetics, but then the milieu around the genetics and what triggers the illness to actually become activated is typically inflammation. So typically when we think about inflammation, we think about there's a genetic predisposition. I had rheumatoid arthritis because my genetic code said I was to get rheumatoid arthritis. But then we believe that there's this unknown trigger. Some people call it the second hit, or at least in medical school, that's what we used to call it. But we don't know what that trigger is. But arguably, and most of the time, it's your lifestyle. So genetic predisposition plus an unknown trigger triggers inflammation, which then triggers illness. And the way we've been taught as physicians is to treat the inflammation and treat the illness. But wouldn't it be interesting if we looked at it differently and we said, okay, well, we know that the lifestyle is the problem. And if the lifestyle is what activates and causes expression of your gene that you're going to get that abnormality, then why not start back further and trigger and treat the lifestyle and the inflammation? And then maybe you wouldn't actually get the illness. So it's another way of looking at how to take care of people and how to heal the body. There are many lifestyle factors that trigger inflammation in our bodies. And I always tell people to think about it like, well, what is it that I'm doing that's wrong? Well, you know, I always think of it in terms of a scale. You have the stresses in your body, but you also have the resources. The stressors are the demands, right? So what are the demands on our body? Well, in 2022 in America and in the West, rather, I should say, the demands are significant, aren't they? And I shouldn't even say the West. It's sort of become a universal problem where there's lack of sleep. Why is there lack of sleep? Well, people don't know how to sleep. They often describe that their mind is always racing, or what is it? Because they're looking at social media right before they go to bed, or we're sleeping less because we're surfing the reels on our Instagram. There's all this mental stress. There's mental stress from work. There's mental stress from family. There's mental stress from sort of expectations that we put on ourselves. There's water pollutants. You're now finding microplastics in all of your waters. There's processed foods, and which most of our foods now have become processed, right? There's hard to get unadulterated food anymore that doesn't come in a box. I mean, 3/4 of our grocery stores are now boxed or bagged foods. And then there's environmental toxins, right? There's too much sun, too little sun. There's too much noise. There's the lack of too much exposure to computers. And all of these things, there's sedentary lifestyle, lack of movement. So all these things are stresses and demands on our body. And it's a scale, right? Because if you have all these things that are demands, well, there's all these resources too, but we seem to forget those resources. Well, what are those resources? Well, there's exercise and yoga, and there's clean water, and there's meditation, and there's sleep, and there's good, healthy eating. And so unlike when our phone goes to 7%, we run over to a charger and we freak out because our phone needs charging, and we find a charger, and that's like a prime directive when we go down low. But we don't know how to charge ourselves. Like, we've forgotten how to charge ourselves. And so most of us have our scales tipped towards stresses and demands, and we really don't focus on the resources. When the cheetah goes and runs for the kill, she or he runs for the kill, and then after that gets the kill, and then sits down and does what? Eats it and recovers. And there's this whole process of recovery that we just don't do. I mean, how many people that you can think about eat and sit down and actually eat and learn and enjoy the meal that aren't on their phones, talking to people, or walking and running, or eating and eating on the go, where there's actually the process of eating and the process of recovering and taking that time to recover and really enjoy your food, prepare your food, enjoy your food, and then actually digest and recover. And that's just sort of lost along the way. And so what's happened is that there's this balances are all tipped towards stresses. And when there's too much stress and not enough resources, well, that's the trigger for inflammation, isn't it? And so those are the lifestyle factors that we're talking about when we're triggering inflammation. So why did I get sick? Well, I got sick, because I had the genes. I had the genes for it. But why did I trigger and get sick when I did? Well, I had 3 children under 4 years old. I was sleeping 4 hours a night. I was working as a full-time cardiologist. I was pureeing baby food at midnight, nursing during the day. trying to run, exercise because that's what I'm supposed to do, and what was sacrificed? Well, my own lack of sleep, excessive amounts of stress. I remember nursing a baby, listening to somebody explain to me that they need to send a patient to me because they're having an acute heart attack. All that stress, and then all the foods that I was eating, because while I was feeding my kids pureed baby food, I myself would just pick up a cheese stick and a Diet Coke, or a cheese stick and a pretzel, and that was often my meal. So much of this chronic illness is triggered by things that you do in your life, and so many of those can be lifestyle related. And so then if you believe that inflammation is the trigger, then treatment of your inflammation and treatment of the things that are triggering that fire in your body is the key to health. So if we think about that, and because I'm a cardiologist, and because I know because heart disease is such an important topic, because it is the #1 killer of men and women in the United States and in the world. And the incident, while the stenting and bypass surgeries have improved and medications have improved things, the incidence of the disease continues to rise. And so I just like to make sure that I emphasize that this is such an important topic. And there's many risk factors for heart disease, and this is just a slide I took offline, and so it's not perfect, but I like that it sort of goes through some of the risk factors, like high blood pressure, high cholesterol. Now 50% of Americans now have high blood pressure, and that's a universal problem in the West. High cholesterol, obesity, most of us are gaining weight and not losing. Diabetes has become a major problem. If you look at Asia, in India in particular, you're seeing so much diabetes, where people don't have a high body mass index but have central obesity, and that becomes a trigger for insulin resistance and diabetes. Still a decent amount of smoking and a decent amount of vaping now, because vaping has become the cooler and quote unquote healthier option. But it's important to remember that while vaping may be better than smoking, it is not healthy. And then stress. So if you think of heart disease as an inflammatory condition, how does that work? Well, you have a genetic predisposition to what? Well, maybe you have a genetic predisposition to certain risk factors, your family history of high blood pressure, and that puts you at a risk, or at high cholesterol. So maybe you have a genetic predisposition to risk factors. But then what about that lifestyle? Well, those poor lifestyle can then increase and worsen risk factors. And then they also can cause, and those risk factors together cause inflammation, but the lifestyle itself causes inflammation, and all that inflammation together puts you at risk for heart attack. So let's talk about how that actually works. Well, normally a blood vessel looks like this top vessel. It's gorgeous. It's nice and soft, and it's like almost like a balloon. It expands and collapses based on the amount of blood that needs to go through. So imagine when you exercise, you need more blood flow. So your heart starts pumping harder. That's why when you exercise, your heart rate goes up, and it starts pushing more blood to the rest of the body, into your muscles, into your lungs, so you can breathe better and faster, and that you can use your muscles when you're exercising. So that's the job of the blood vessel. And there's a tiny layer of cells right in the sort of the layer that's most close to the blood. That's called the endothelium, and that's job is really to be in charge of a lot of that opening and closing of cells. Well, what happens over time is when you develop those risk factors, or maybe you have high blood pressure, you smoked when you were younger, or you eat poorly, or you're not moving, and you're eating more than you're processing. Well, all of those things, or you become diabetic, those things become damaged. They start damaging the blood vessel. And so if you have a blood vessel that's open to the air, like it's on your skin, and you don't have a problem necessarily with a scab, but inside a blood vessel, which is a closed unit, the size of the scab matters. So what happens is that you damage your blood vessel with all of these risk factors. Too much sugar or high blood pressure makes the blood vessel stiff, and you get a little crack in your blood vessel. And the crack in the blood vessel, your body says, "Oh my God, there's a crack in my blood vessel." So it brings the platelets over to heal it, and so it puts all these. And it starts building that scab, and then there's fibrin and sort of other skin cells, and then there's cholesterol that comes by and floats by in that blood vessel, and all those things attach, and that becomes the formation of a plaque, which is what you see in the middle blood vessel. And the blood flow still goes by, but you still build plaque. And so we see plaque actually in kids as young as 6 and 7 years old who've died of leukemia, and 18 and 19-year-olds who've died in Vietnam and Korea. All had plaque in their, large percentage of people had plaque in their heart, but you don't notice it because you don't feel it until you get a significant amount of blockage, unless you get inflammation. So imagine you have the blood vessel in the middle and it's an irritated blood vessel, and something triggers that blood vessel to be unstable or unhappy. We think that is inflammation. And what happens is the clog or the clot or the plaque gets irritated and it ruptures. And what happens is what happens in the third vessel, which that plaque ruptures, and then it causes acute blockage of the blood vessel. That's the acute heart attack. That's the person who goes to bed at night and then doesn't wake up in the morning. That's the what happened to Carrie Fisher from Star Wars, Princess Leia, and happens to so many people and underappreciated because that is the acute heart attack. You don't feel any symptoms because you have adequate blood flow until there's then the blood vessel or the plaque gets irritated and it ruptures and it causes an acute blockage. I tell you this because it's really important to understand heart disease and to understand that people cannot have symptoms and then all of a sudden do have symptoms. So the best way to handle that is to work again on how you treat your body and to eliminate those risk factors, which is why I'm here today. So this is a slide just to remind you that heart disease continues to be the #1 cause of death. Again, it says United States, but this is really a universal problem and it is a worldwide global issue. Followed by cancer, stroke, Alzheimer's, all of which arguably have some level of being preventable. Not only do we know that with those risk factors, we know that 50% of Americans now have high blood pressure. And again, that's a West problem and not just an American problem, where we're seeing about 11% of the population with diabetes and 35% of the patients have prediabetes. So these are people who have known diabetes, they have elevated blood sugars, but they haven't had a full diagnosis. So often they have no symptoms, they just have elevated sugars. So what's the problem? What is the problem with everybody getting all these risk factors and having these problems? Well, this comes from JAMA, which is one of our big journals in 2018. And what they do is every couple of years, they look at the state of health in the US and of course in the West, and they looked at the burden of disease. And they say, okay, what is actually killing us? And so if you can see that the #1 cause of risk factors and related deaths is actually dietary risk. And that dietary risk is primarily led by cardiovascular disease or heart disease. So some people call this diet the SAD diet because we in America call it the standard American diet, but it's really, again, the Western diet, so the standard Western diet. It just doesn't, SWD isn't as pretty as SAD. So what's wrong with our diet? Well, our diet is primarily and has shifted now over the last 20 or 30 years to really being high and heavy in meat, specifically red meat, because we need meat, right? Because meat gives us protein, and that's the only way we'll be strong and energized, right? But it's also refined grains. So we're in the society in the world where we need instant foods and foods that are quick. Well, the only way to do that is we refine them. Processed foods, so we need things to last longer because we need things quick. We need to be able to pull them out of the freezer and microwave them. So we've moved towards these canned foods, or everything's in the processed fashion. But we also eat a lot of high-fat dairy. We eat a lot of desserts, non-nutritious calories like high sugar sweetened beverages. Now 0.9% of adolescents and only 2 to 3% of adults attain the daily recommended fruit and vegetable intake. 2 to 3% of adults and 0.9% of adolescents. About 75% of packaged foods in the US now contain added sugars, and most of that comes from sugar sweetened beverages. What about a Southern diet? It's a diet that's standard in, sometimes we'll see in the South of America, but is very common in parts of England, as I've just been to England recently, and I go there actually quite often, where it's just the kind of more of the fried meats, lots of foods cooked in oils and butter, and you get some vegetables, but also a high propensity of refined breads and meats. Well, what is that associated with? Well, it's associated with a 56% higher risk of disease than somebody who's not eating that way, increased risk of kidney disease, and increased risk of stroke. And people don't realize that stroke and heart disease are the same problem. And it's not that one is different than the other. It's the exact same pathology or the exact reasons that trigger one, trigger the other. What's also happening, besides the food quality changing towards more refined foods, excess amounts of meats and dairy, and lots of sugar sweetened beverages, the size of our food has gone up. So the typical food in 1950 used to look like the one on the left, where a burger might have been about 4 ounces, but now that same burger is about 12 ounces. Sodas now gone from 7 ounces to about 42 ounces. So not only is the food quality worsened, but the size of everything is, so we're eating more and more of it. So now our children look less like the child on the left and more like the child on the right. Well, while, maybe this is just the way it's going to be, maybe you just kind of accept your fate. People said to me, well, my dad had high blood pressure. My dad had a heart attack at 45. This is just what I accept. But is that really true? Is this really what we need to be doing? And this is one of my favorite slides of the entire talk is this slide. So I just want to pay attention to it for a sec here. So on the x-axis, this is genetic risk, and the y-axis is calcium scoring. So that's calcium in your heart, and that's associated, that's kind of atheromatosis or heart disease. And then there's low, intermediate, and high genetic risk. And then there's red, unfavorable lifestyle, and blue, favorable lifestyle. So let's look. So if you have a low genetic risk, meaning everybody in your family lives to 1,000 years old, and then you have a good lifestyle, well, then your risk of having plaque in your heart is about 15. So let's just use that number 15. And then we say, well, what if you have that low genetic risk and you have an unfavorable lifestyle? Well, you can easily double your risk by doing up to 31. Well, what if you have a high genetic risk? Dad had a heart attack at 45 or 50 years old. What about you? So if you have an unfavorable risk, your number will be 64. Or if you have an unfavorable lifestyle, you'll have a number as high as 64. But if you have a favorable lifestyle, you can reduce your risk by half. So does lifestyle matter? Absolutely. So much so that all of our guidelines now emphasize adherence to a healthy lifestyle. And really focus on primary prevention, which is disease before you get sick. So with now a big emphasis on diet, you can see in the bottom at around 7 o'clock, you can see diet and emphasis on intake of fruits, vegetables, nuts, legumes, fish, and whole grains. Including in our secondary prevention, which is when you already have disease, emphasizing that people who have heart disease already still, despite optimal therapies, medical therapies, there's just this critical lack of targets. Like we're not targeting so many of the other problems, some of which is inflammation. There's that residual inflammatory risk, which is that second arrow, and elevated triglycerides, which comes from eating, residual diabetes risk. So these are all risk factors that we are not effective at in targeting with our medications for heart disease. And just a reminder again that we are trying to focus on it because we really want people to focus on prevention of disease rather than reactive. So prevent versus react. And so that's really focusing on prevention and try to reduce excess calories and improving diet quality. So here, drivers of poor diet quality, and reminding that all those dietary qualities and excess amounts of them are just putting us at risk for cardiovascular disease. And then similarly, if we just work on diet and lifestyle, we can decrease there. Again, there's that inflammation, my favorite word, and then we can decrease your risk of getting heart disease. So why isn't that you're hearing about it from your doctors? Well, because we don't know anything about it, actually. Doctors were surveyed, and this is a study we did where we looked and polled the cardiologists from around America, and then we also did it again internationally. And then we found that 62% of cardiologists spend less than 3 minutes of their visit on nutritional counseling. Well, why is that? Again, this is a study that we also did, which looked at doctors and said, well, why isn't that we spend a lot of time on it? Well, one of the problems is that there's no time. The visits are so short, and because you have a more standardized system, maybe you have arguably a little bit more time, but that's not what I hear from my colleagues in the UK. And part of it is because we just don't know anything. So if you look at doctors' education, and this is a cardiology-centric survey we did, and they said that they received 1% of doctors felt they received a high level of nutrition education that gave them excellent skills for counseling patients. FIT is fellows in training. So the people who are actually in training, they're not any better. In fact, they said 0%. So almost over 90% of people said they received little to no education in nutrition. So I just want to segue that and to say, well, the problem is you're not getting your education from your doctors, which is a really big problem. But there's some of us who've gone on and done extra training. Me, admittedly, I started this process because of my own illness. I couldn't accept that I had to take medications for the rest of my life, which is what I was told, that I had an incurable illness and that I wouldn't get better. And so I started on my own path to figure out what is it that I'm missing here? What are we not getting, what we did not get in medical school? So it took me a year to understand and research and go around the country and learn about these diets and understand about lifestyle and the impact. I studied the gut, I studied inflammation. And I'm proud to say that about 1 year after my diagnosis, or I guess 2 years after my diagnosis, 1 year after I started medications, I came off of all of my medications, and I'm now almost 9 years without medications, and I'm the strongest I've ever been. So let's talk about diets, and I like to break them down briefly and talk about plant-based diets. And what we know is that there's the DASH style diet, vegetarian, vegan, whole food, plant-based. And what are all these things actually mean? Well, a DASH style diet is actually one that a lot of people was used in a trial, but people talk about the DASH diet. Well, what is that? Well, compared to a Western diet, it's actually more fruits and vegetables, but there's low-fat dairy, there's nuts, legumes, fish, fiber, and there's a less red and processed meats, very little sweet and saturated fat. And the reason I think it's important to explain what these all are is because I think that these words are used interchangeably, and they really are quite different. But they do have some commonalities, of course. So a vegetarian, and typically when we think about vegetarian, that's a lacto-ovo vegetarian, which is a very Asian thing. Many Asians, especially Indians, are lacto-ovo vegetarians, where they don't eat meat, but they'll drink milk and cheese, and they'll eat fruits and vegetables and grains. And whether those are refined or not, that's not part of the definition. A vegan is different than a whole food plant-based person. And a vegan is somebody who doesn't eat animal products or use animal products, doesn't wear animal products. It's an ethical decision not to eat animals. But that doesn't mean you can't eat unhealthy vegan foods such as Oreos or Coca-Cola or French fries, which are all unhealthy vegan foods. And then there's the whole food plant-based person, which is the person who tries to be kind of the healthy vegan, which is whole grains, fruits and vegetables, beans, and no animal products. And whether they wear animal products or not, that's their decision. Ultimately, it's not an ethical decision to go whole food plant-based. All these diets are abundant in carbohydrates, and ideally these would be complex carbohydrates. Well, there's multiple studies that talk about diet that assess diet in the past, and the early studies were on the DASH diet, and that's why the DASH diet is so popular, because the DASH diet was one of the first studies that looked at patients with blood pressure problems and put high blood pressure patients on sort of effectively a plant-based diet. And what they were able to find here, systolic blood pressure and diastolic on the here, so that's the top number and the bottom number in your blood pressure, and this is time. And this is a diet in green that's low in fruits and vegetables, and red, which is high in fruits and vegetables. And you can see that in blood pressure, there's a significant drop in blood pressure just by changing your diet. So going from the low fruits and vegetable diet to the high fruits and vegetable diet, and you can see that drop within 2 weeks in the study we did just this last fall. We were able to show that you can see that blood pressure change in 6 days. So what about the salt data? Like, isn't that what DASH is, all about salt? Well, yes and no. The DASH data, salt data, came actually as the second study, which was the follow-up study to eating more plant-based. So what they did was they had the control diet, and then they put people on the DASH diet, and then they took those DASH patients and then they adjusted their sodium, so a high, medium, and low level of sodium. So that's what you see at the sodium level here on the x-axis and blood pressure on the y. And what you can see is that if you eat a control diet versus a DASH diet, well, there's a significant difference in blood pressure. So the DASH diet wins. But also on top of that, if you eat high sodium versus low sodium, there shows that even a low sodium diet is even better than just a high sodium DASH diet. And that's why I like to show this slide, to remind us, because many of us are on blood pressure medications, and to show that this is the effect on blood pressure. And we want to be on this side. That means that the intervention actually caused your blood pressure to go down. And you can see that ACE inhibitors like lisinopril and quinapril, they're very effective. Beta blockers, calcium channel blockers, they all drop your blood pressure about 12 to 15 millimeters of mercury. But what if you just cut sodium and you didn't adjust the diet at all? You drop blood pressure about 7 millimeters of mercury. If you did a DASH diet and don't cut sodium, you drop blood pressure about 12 millimeters of mercury, or 11.5. But what if you did a DASH diet plus low sodium? You can drop somebody's blood pressure 21 millimeters of mercury. Well, that throws out any medication that I'm able to give, which is why people end up on multiple medications to treat their blood pressure, but dietary change can do it in one fell swoop. I'm going to skip this out of time. Just this one study here, but this is also a evaluation of the DASH diet. And this just really shows that the more adherent you are to a DASH diet, there was a reduction in dying of heart disease, dying of stroke, and just dying overall. And what is that optimal number of fruits and vegetables? Also coming from the DASH study, that shows that we really want to be eating about 5 to 7 to almost 10 servings of fruits and vegetables today, but at least 5 servings. And 1 serving of fruits and vegetables is not 3 strawberries. It is a cup of uncooked vegetables, a half a cup of cooked vegetables, or a baseball-sized fruit. But there's there's lots of studies on veganism as well. So if this is from Neil Barnard, where he put people that were diabetic on a plant-based diet, a low-fat plant-based diet, and he was able to show that over a diabetic diet, so this is the American Diabetic Association's diet, compared to a plant-based diet. And he was able to show that he was able to make people lose more weight, bring down their cholesterol, and bring down their blood sugars, where A1C fell 1.2 points in the vegan group compared to only 0.3 points in the ADA group. And now remember that metformin or glucophage, which is what we use for first line for diabetes often, can only be counted on to drop your blood sugar by 1 point. And this is just showing body mass index, diabetes, and high blood pressure. And it shows that when you eat non-veg to lacto-veg to vegan, you can see that the body mass index is more reduced. And when you eat vegan, your diabetes rate goes down from 1 to 0.22. So we're reducing risk so significantly by shifting people to more plant-based. And then look at high blood pressure. Here's 1 for non-vegetarian, 0.45 for lacto-ovo, but look at that 0.25 for vegan. And then what about inflammation, that big inflammation number? Well, these are patients who had stents put in their heart, and then they were put on a plant-based diet and over the American Heart Association diet. So the American Heart Association diet is, got a fat consideration, but does allow a lot of lean animal products. And if you compare that to putting them on a plant-based diet, the inflammation, so hsCRP is an inflammatory marker, showed a more significant reduction in inflammation. I'm just looking at the time here, so I'm talking, I think, slower than I usually do, or something's wrong with me today. So I'll just talk about 2 more studies here, and just reminding you, this is Dean Ornish's group back in the 1990s. Where he actually took people with heart disease, and he said, okay, well, let me just take these heart disease patients and put them on a plant-based diet. But he did other things. He improved their exercise. He gave them stress management. He did social connection by bringing them in a group environment and talked about smoking. And then what he did was he compared it from a control group that didn't get this group intervention and then versus treatment. So everybody was on medical therapy, arguably a much worse medical therapy than we have now. Not because of his fault, but just because of the times. And this is diameter stenosis on the y-axis and time on the x-axis. And what you can see is that if you're looking at plaque, you can see the control group had increased plaque over time, despite medical therapy. Whereas the people in the treatment group actually had a reduction in their plaque. So while you could argue, as a scientist, I would say, well, medical therapy is so different now, I'm not sure the same lines would happen. I agree with that. I agree with my question, because that is true. When we have statins and some of the newer therapies, could we maybe make these lines would be closer together? Probably. But I think the important thing to remember is that it's not really about that. It's to remind you that overall, if you change your lifestyle, look at the impact that you can make. And this is Esselstyn's work, my good friend Caldwell Esselstyn, where he looked at patients, he put them on a plant-based diet. And these are people who refuse statin therapy. And that's why it's important to note that. And you can see here, this is a stress test on the top. And what you're supposed to see is a golden donut. So this little space, there's no blood flow. And within 3 weeks of putting somebody on a plant-based diet, they had complete improvement in their stress test. So the blood flow improved 3 weeks. I mean, that's crazy. And then if you do a heart catheterization where we look at the blood flow, you can see that there is an area of decreased blockage, the decreased blood flow here. And see that ratty looking vessel here. And within 30 months, 32 months of actually changing that same patient's diet, look at the blood flow. It is gorgeous. So diet matters. I'm just going to skip that and then bring up a little bit on the Mediterranean diet. So a lot of people like to eat Mediterranean style, and that's a very popular diet, and there's absolutely nothing wrong with it. I just like to emphasize a few things. So the base of the pure Mediterranean diet is a plant-based diet. It's fruits, vegetables, grains, olive oil, beans, nuts, seeds, legumes, herbs, and spices. The differences are that there's a little bit of animal products, there's more olive oil and maybe some wine. Well, we know from studies in secondary and primary prevention that if you put people on a Mediterranean diet compared to a standard American diet, you make people live longer. So there was a 30% reduction in an endpoint of heart attack, stroke, and death. And that was primarily driven by strokes. And so there was a reduction in that endpoint by just changing people's diet. It didn't matter if you ate more extra virgin olive oil or if you ate more nuts, as long as you were eating Mediterranean, you would improve and reduce risk of those heart disease events. But if you look at those same Mediterranean patients and you looked specifically at what they were eating, you would see, and this is mortality, so dying rate on the y-axis, and adherence, so meaning they actually ate the most pro-vegetarian. So of the people who ate that Mediterranean style diet, so you want your bar to be lower here. So the more adherence to a pro-vegetarian pattern, the people who ate the most vegetarian of the Mediterranean actually did the best. So reminding us that the key is not the Mediterranean necessarily, but just to eat more plants. So why did Time Magazine and some of these other organizations say eat butter, and scientists labeled the wrong enemy? Fat is not the enemy, and why are they wrong? And they actually said, and there was a more recent study that said that high carbs are actually your problem. That's why the ketogenic diet is so popular, right? Because we have these studies that say, hey, carbs are the enemy, and fat is actually associated with lower mortality. So is that really right? Well, let's look at the ketogenic diet, which is a very low carbohydrate diet. So this is LC for low carb, moderate carb, and high carb. And you can see that the low carb, and that's what we'll focus on, is about 75% or 74% fat, and 100 grams of that is saturated fat per day, 100 grams of saturated fat. Well, is that a problem? So this is from the British Medical Journal in 2016, and there's many like this that really showed that high dairy dietary intake of major saturated fats is associated with heart disease. So dietary recommendations for prevention of heart disease should continue to focus on replacing saturated fat with more healthy sources of energy. So we also know that people will say, well, when I eat those ketogenic diets, I'm eating all the saturated fat, but my lipids get better. Well, is that really true? So LDL is that bad cholesterol. And you can see that there's a huge difference in people who eat on a ketogenic diet in terms of their LDL. And some people's LDL does go down, but a lot of people's goes significantly higher. And there's just so many studies that show if you take people off of saturated fat and give them unsaturated fat, that you make them better. And this is a nice slide that I love, which is changes in mortality on the y-axis and fat on the x-axis. And so what you can see is that you want to be on the bottom of the zero. There's zero in the middle there. And if you eat trans fats, which are those hydrogenated fats, or saturated fat, you actually make people worse. But if you eat monounsaturated and polyunsaturated fat, you make people better. Similarly, they looked at carbohydrates, and so it's nice to see the carb data here. And you can see you want to be on the left side of this unity line, and you can see trans fats, well, they're going to make people worse. And then if you use unsaturated fats, you make people better. But what if you use carbs? Well, if they're refined carbohydrates, again, there's that red, you make people worse, but carbohydrates from whole grains, you make people better. And since carbs are not the enemy, we know from studies that about 50 to 55% of your diet should be carbohydrates. When you eat too many carbs, 80 to 85%, you do increase mortality or risk. But if you eat too few, that's very low carbohydrate diets, that's also increases your risk significantly. So carbohydrates are not the enemy, but and that saturated fat is one of the enemies. Here's the problem. So if you eat, so what is that study that says that fat's the enemy? Like, how does that all reconcile in our head? Well, this is how it is. If you eat saturated fat that looks like the food on the left, and you replace it with a low fiber, highly processed pasta dish, then you're going to make people worse. But if you take a saturated fat and you give them a complex carbohydrate like beans and sweet potatoes and greens, then you're going to make people better. So we said in our editorial for that article, we said, it's not that saturated fat is good and that carbs are bad, but rather that saturated fat is bad and refined simple carbohydrates are as bad, if not worse. So I'm sorry about that. So while you may think that, so the answer is not that carbohydrates are bad, it's that carbohydrates that are refined are bad, and arguably the worst thing you can eat, and saturated fat comes in as a very close second. So we really want to be eating more complex carbohydrates like the ones on the right, and not the simple carbohydrates like the one on the left. And there is such a thing as a healthy diet, a healthy plant-based diet. So we really want to be focusing on eating fruits and vegetables, whole grains, nuts and seeds, legumes, And that's where we want to focus, and not foods that look like this. And that's why our 2019 cardiology guidelines show that and emphasize that we want you to eat a diet of high of vegetables, fruits, legumes, nuts, whole grains, and fish to decrease ASCVD risk. And really want to focus on food on the left side of this picture and not foods on the right. Again, we want to focus on eating more unsaturated fats that decrease heart disease risk, whole grains, and not those refined starches, refined foods like cookies and cakes, and those highly processed hydrogenated foods. And when you look at the dietary components and you see, and you break it down and say, what specifically makes you improve your lifespan in terms of heart disease prevention, you want to be on the left side of this unity line. You can see that meats, refined grains, and even dairy cross the line, meaning they're not of significant benefit and are harmful. Whereas fish, fruits, vegetables, nuts, and whole grains, in that order, you can see have the most significant impact in terms of risk prevention. So I just want to spend 2 minutes on my prevention clinic, kind of going through what I do in my clinic. So I run a prevention clinic at the University of Florida. I also do a lot of telemedicine, which has been a shift where I wanted to spend more time with patients. So I do a telemedicine practice. And what we do in our practice is we focus on a lot of things. Our targets are to treat risk factors for heart disease and for other chronic illnesses, and really to treat inflammation. We use medications and lifestyle to reduce risk factors and decrease inflammation. So I'm not afraid of medications. I use them all the time, but I use a combination approach, and often people don't end up needing their medications for long if they need them at all. But we do 1 hour visits. Even if I do telemedicine, I do them as 1 hour, often 60 to 70-minute visits, where we focus on meditation and yoga and extensive amounts of nutrition education. And we publish the data from our prevention clinic because we compared it to other cardiologists, and we found that we have better quality of life. We have better blood pressures, we have better reduction in medications, and we have better cholesterol. So often when I work with patients, I try to teach them about and how to get them to change, because people tell me every single day, doc, I can't change. I don't understand. This is too hard. This is something different than I ever do. And they'll say, hi, baby. You want us to first, you want to eliminate red meat, then go to chicken, and then your fish, and really try to eliminate your dairy, try to avoid trans fats and saturated fats, all of your processed and refined foods, and then adding back in loads of fruits and vegetables, omega-3 fatty acids, anti-inflammatory foods, and if fats should be unsaturated, complex carbohydrates, and my favorite, fermented foods. So we've changed the whole hospital paradigm at the University of Florida, where we have discharge education. So when your patient walks in, it's not like, hey, sir, you had a stent in your heart, here are your medicines, good luck. Which is unfortunately how most medical care is. We give people discharge education and we say, here's your education packet. We know you're scared. We know that you're depressed. We know you're nervous. We got you. We're going to teach you how to eat. We're going to teach you how to reduce your stress. We have them watch videos. We send them to cardiac rehab, and we teach them how to improve their lifestyle. We also implemented a 100% plant-based menu at the University of Florida, so any patient can eat 100% plant-based menu. And we also do a lot of education. I run cooking classes and education for physicians and allied professionals, because we just don't know anything as doctors, and we need to, because people look at us as doctors to answer the questions about nutrition, and as doctors, we really don't know. I've heard many of my colleagues say, oh, just eat any diet, it doesn't really matter. Or they'll say, well, eat low carb, because low carb is the way to go, and that's where you're going to lose weight. I had a surgeon come to me who's a cardiac surgeon, and he came to me about a year ago and he said, Monica, I need to talk to you about nutrition. I said, okay, what's up? And he said, I'm seeing this patient as a consult, and he's lost 100 pounds in the last year eating a low carb ketogenic diet. And I said, okay, that's amazing. That's great. Tell me something. What are you seeing him for as your consult? And he's like, oh, well, he needs 4-vessel bypass. So, and again, that's the important thing to connect, is that just because you can lose weight on a low carbohydrate diet doesn't mean that you can be healthy. So I think my hopes for the future are to really focus on education. That's why I do these talks. We're focused on teaching doctors, allied professionals, and also consumers. You need to know what you're eating. You need to understand why food is important. And you need to know that you have the ability to change and improve your lifestyle with the things that you do. And it's not just nutrition. You have to really work on so many other things, your stress reduction, your movement, all of those things are super important. But it's an exciting time. I want you to remember that change is possible, that there's a real connection between what you eat and inflammation and chronic illness, and that you can be part of the change. You can do this. You can change yourself. You can change your family. My kids are 100% plant-based. I didn't tell them to eat plant-based. I just cooked that way. When they'd go out, when they were younger, they would go out and eat chicken fingers. And then over time that they have on their own, because of the taste and the palate that they have adopted because of the way I cook, they identify themselves as vegan or 100% plant-based. So what can be done? Where should you start? Because it's overwhelming, like, oh my gosh, I don't know what to do. Well, I often tell people the focus should be just eat more plants. If you could just eat more plants all day, every day, you're going to be in good shape. We want you to eat loads and loads of fiber, no processed, low fiber, refined foods. We want you to eat lots of fermented foods and try to do the best you can every day a little bit better. And remember that imbalance is equal to inflammation. If you have too much stress and not enough resources, you will get sick. And you may not at the beginning. When in our 20s, we think we're so invincible, but over time, these things do catch up to us if you just become depleted. So if you have two choices, we can perform triple bypass surgery, where we would take a vein out of your chest, out of your thigh, and open your chest, so we can sew the vein onto your coronary artery. This costs about $100,000 and will keep you laid up for about 2 months. Or we could put you on a vegan diet. A vegan diet, GDoc, that sounds pretty extreme. And then there's my social media, my just a sort of a comment, that's our book called Body on Fire on Inflammation, and my email address if anybody wants to connect. Thank you so much.
Thank you, Monica. That was incredibly inspiring. And I know that you're also you just briefly mentioned about the plant-based menu, and I know that you're working with Four Roots Farm as well around, improving soil health and doing so much educational work. It was incredibly inspiring. And I just checked that your book is available in the UK as well on Amazon. So most of our listeners are here in the UK, so do go and check that out for sure. I'm just going to stop the slide share so that, yeah, okay, wonderful. So there's already a few questions, but we don't have that much time, so I'm going to dive straight in. One of the big questions is around fish, and I would love to know your views on that, because of course the guidelines still include that. What are your views on that within the context of a heart-healthy diet?
So of all types of animal products that have the best data on them, it's fish. So if you're going to choose an animal product to eat, it would be fish. But you have to remember that fish is not a clean product, right? There's the metals, there's the dioxins, there's the PBB, and all of these toxins that are in fish that we'll be eating. And plus, which we didn't go through, is that they actually can produce something called trimethylamine oxide, which is inflammatory and associated with chronic illness as well. And so while fish is probably the best choice, I would still say that if you can avoid it, I would rather people avoid eating fish. But if they feel like a little bit of fish adds joy to their life, then I don't tell them not to, but then really focus on eating fish that are high in omega-3 fatty acids, which are anti-inflammatory. So that would be like salmon and tuna and bluefish and sardines, but also then to really try to get clean fish, which is very tricky now, and really look at the environmental workers group. And the environmental workers group puts out a list of sort of the low and high mercury fish. So like I said, my feeling is I try not to sweat the small stuff. I want people to eat more plants, period. If you eat a little bit of fish here and there, okay. Would I like you not to? Yeah. But if you feel like it adds to your life, okay.
And I'm sure you've been asked this literally 1,000, probably 10,000 times, but are your views sort of similar with regards to oil in terms of it's something that you would include if it adds joy, but what are your views in terms of
Yeah. Yeah, I mean, this is the $1 million question, and the one that I'm studying in my research project, which is I'm putting, so we know a Mediterranean diet is a high fat, because it's an olive oil diet, and so is having an olive oil or excess amount of oil good for your health? Well, there's lots of things to think about olive oil. Well, it's high in polyphenol or avocado oil. It's a monounsaturated fat, which increases your HDL cholesterol. So, and these polyphenols are considered anti-inflammatory. So many things about olive oil are interesting. But there's also data to show that even in animal studies that every oil causes plaque in your heart. So I often tell people, and so the difference between a plant-based diet and a Mediterranean diet is the amount of fat in the oil effectively. And so has the study ever been done to look at Mediterranean versus plant-based diet and cardiovascular disease? No, it's never been done. It may never be done because no one's going to support it. But what we did do in our study is we put patients at risk for heart disease, and we put them on 100% whole food plant-based diet. And then we randomized them to high olive oil and then low olive oil. So the high olive oil is Mediterranean style and low olive oil is more plant-based style. And we put everybody in it, and we want to look at the numbers, and we want to see, does olive oil actually matter? So what I tell people is, in terms of oil, is that probably less is more. I don't eat oil for my health because I'm not convinced that that data is there. That if you eat and cook a little bit of oil, like I'm Indian and I like to saute onions to make Indian food, so I might use a little bit of oil for that. But other than that, I try not to eat oils, and I just eat a little bit if I'm going to eat it. And I always tell people to avoid really those highly processed oils, which there are so many of them now, and really stay away from coconut oil, which is really high in saturated fat, despite it being a medium chain fat. It's one that we don't advocate as a society until there's more information and data that it's better, and we have not seen that. So if you're going to eat oil, I typically stick with avocado or olive oil. But remember, olive oil has a lower smoke point, so you can't really cook it like you can maybe with avocado oil. And then try to eat less is more.
No, I think that makes perfect sense. So I would love to know just your experience of working with South Asian patients. I had a quick look at the American College of Cardiology and the specific guidelines, and they were definitely stricter for South Asian patients. And I was wondering if you had experience working with this group, and obviously we see high rates of.
I mean, Indians and Asians in Southeast Asia, and it's not just Indians, it's the whole Southeast Asian subcontinent, and arguably just South Asia at this point. I used to live in Malaysia. The amount of heart disease is ridiculous there. And we're just seeing that in all over Asia now, and really all of South Asia. And I can't even say South Asia anymore. It's such a problem. But to specifically hone in on that Southeast Asian, which is that I always tell people Indians have to be better. Genetically, there's lots of interesting genetic data on Indians. I think the things to remember are that, so many of Indians grew up on ghee that was a trans fat, a hydrogenated ghee. So remember, ghee is clarified butter, but in the 1970s and 80s, they hydrogenated it to increase its shelf life. And that really, a whole generation of people grew up eating hydrogenated ghees, which is a travesty, which is all that trans fat we added into the system. And then there's so much refined food that's being eaten in Asian cultures now. And so what we classically see is the Asian who has a low BMI, where they don't look like they're overweight, but then they have the central paunch, which puts them at risk for metabolic syndrome and increased diabetes rates. And people don't realize that. So some people have proposed to the WHO, the World Health Organization, that we should reduce the BMI for Asians, and there's considered the Asian BMI, because we do need to be better because our risks are higher, because there's this polygenic, meaning there's multiple genes that are probably put us at higher risk. And then add that highly inflammatory diet that everybody's eating. We've exported all of the fast foods from the West, have all now gone over there, and they're becoming more and more sedentary. And it's just it's a maelstrom. It's a tempest in a teapot.
Yeah, I couldn't agree more with everything you said. There is a different BMI cutoff guideline here in the UK and the NHS, but I think we had Dr. Kanaya, who I think you know through the Masala study and things, on our webinar platform, and she showed, she showed that above a BMI of 19, the risk for a South Asian person is the same as a white European or, you know, white American person with a BMI of 36. So it was
It's amazing. It's amazing. I mean, we're so lacking in studies, and the Masala study is one of the only big studies that we have. And so but so much is lacking in terms of Asian interventions and really understanding the Asian genome and the Asian risk. But the bottom line is we have to be better.
Yeah, couldn't agree more. So I think there's so many more questions that people have asked, and I want to say to everyone who's asked a question, firstly, thank you, and thank you everyone who's joined. It's the summertime and it's evening in the UK where everyone's kind of putting their kids to bed or kind of winding down. So I appreciate everyone who's joined, and I know that lots of our members watch this recording on our platform as well. But if you've got all these specific questions, do check out Dr. Agarwal's book, because it is packed with information, but also hopefully your website also lists where you're speaking. I know you've got lots of upcoming events and things like that where people can find you and hear you speak again. And there are also some specific nutrition questions around things like how to get enough calories on a plant-based diet. But I would urge you to check out plant-basedhealthprofessionals.com. Almost all of our resources are free of charge. So we have so many different fact sheets on things like calorie density, how to include more, how to adopt a whole food plant-based diet. We have a free 21-day challenge as well. So I know that there's lots of new people on tonight, and I would definitely urge you to go and check out those resources for free. But I just want to thank you, Dr. Agarwal, for the incredible presentation and giving up your valuable time. I know how incredibly busy you are, and we didn't get time to talk about the plant-based menu that you have.
I'm sorry, I think I talked too much. Sorry about that.
No, it was brilliant. But I think we'll have to definitely, you know, get more information from you on that, because actually lots of our members, we're geared towards healthcare professionals, and lots of our members do want to implement plant-based menus in their own hospital.
Good, I love hearing that.
Yeah, so I think it would be great to have you on another time just to talk about that, because that is a huge passion of lots of our dietitians, nutritionists, surgeons, GPs in our group.
So what I would say to that is, because there are, I'm just also seeing your question and answer come up too with all these questions I didn't answer, and I'm sorry about that. But what I would say is that feel free to reach out and if you put that up on social media or on email. On email, I will tell you, I get, as all of us, we get loads of emails, so sometimes those fall to the bottom, but I try to be good about responding to questions on social media. And if you ask me and you put in your subject line, interest in plant-based menu, I'm happy to send you some of our information. And I would say that there's a paper two papers we published, one in the American Journal of Medicine and one in the American Journal of Lifestyle Medicine, both on our hospital-based menu. And one was sort of on the state of hospitals everywhere and what's happening, and the one is on what we experienced in terms of what were the resistances and obstacles and how we overcame them. And those two articles are worth looking at, especially for anybody, because we even published our actual menu, which is in that article.
Oh, that sounds incredibly helpful. It's always helpful to have a case study like this, because I think so many people, it's hard to know where to start, especially when you're trying to get this kind of level of change implemented. But that would be super helpful, and I can add that to our website for our members, and, you know, in a private section and things, if you think that would be helpful. But we'll connect about that separately. But yeah, thank you so much again for the presentation, and for being here and connecting with all the UK health professionals. Hopefully, if we ever have another UK conference or event, we can reconnect. Did you say that you sometimes come to the UK?
Oh yeah, I have some very good friends that are, when I used to live in Malaysia, a lot of Brits were over there as expats as well. And we went to the British, my kids went to the British international school. And so we have a load of friends that are British, and we often are in the UK.
That's wonderful to hear. Well, I wish you all the best, and thank you so much for sharing your time. We're going to definitely add your book to our list of resources on our website.
Sounds great. And thank you so much. Thanks for having me. Bye-bye.
Thank you. Bye, everyone, and good night.